This film has been prepared to present the philosophy that the ultimate goal of our training program is management of the patient entrusted to our care. Our evaluation of the patient, our preoperative care, our conduct of anesthesia during surgery, our post-operative care are all part of the total responsibility of the anesthesiologist. The development of anesthetic agents such as halothane demand highly sophisticated skills and techniques for their administration. Surgery is a complex team operation. The patient, the anesthesiologist, the nurse, members of the medical staff must function efficiently if the patient is to receive the best medical care. The clinical management of any anesthesia begins with a preoperative consultation with the patient and, if possible, the patient's family. The resident prepares for this consultation with the assistance of the staff anesthesiologist. He studies the patient's record with special attention to the medical history, the physical examination, the laboratory and X-ray findings, and the impressions of other consultants. Interview skills are important. Through repeated experience, the anesthesiologist learns to elicit adequate information for proper evaluation of his patient. By weighing his careful study, the procedure contemplated, the family situation, he makes his choice of preoperative sedation and the anesthetic agent. This thoughtful, considerate interview with the patient and family dispels apprehensions and fears about the anesthetic and its administration. Important factors in formulating his preoperative evaluation include the patient's fears, likes and dislikes, family worries. On the objective side, his physical status, vigor, stamina, and other disease involvement, plus the laboratory findings. He weighs these against the surgery contemplated, past surgical and anesthetic history, the skill and experience of the surgeon. From all these considerations come his recommendations for the clinical management of the anesthesia. To produce adequate sedation with minimal depression, combinations of barbiturates, narcotics, and belladonna-like drugs will be used for premedication. Sedatives are prescribed as an extension of his concern and understanding of his patient. At best, they are only an adjunct to the patient interview. Halothane is a new, widely tested inhalation anesthetic introduced from Great Britain. Inhalation anesthesia is the backbone of anesthetic practice, and halothane represents a significant advance. The ideal anesthetic agent would be non-irritating with minimal toxicity. It would allow rapid induction and rapid recovery. It would be non-flammable and non-explosive. It would be potent and controllable, so that the necessary level of anesthesia could be achieved and maintained or rapidly regulated. Halothane possesses many of these properties. Halothane, a clear, heavy liquid, specific gravity 1.86 at 20 degrees centigrade, is an almost completely halogenated hydrocarbon of the ethane series. Attempts to ignite halothane meet with failure. Ether, under similar conditions, ignites with a flash. Halothane is compatible with soda lime at all usable temperatures. It slowly decomposes on exposure to light, forming volatile acids. Storage in amber bottles eliminates this hazard. This circle of dots represents the respiratory system in man, and this circle of blue dots represents the circulatory system. Normal function of these systems results in transportation of oxygen to the brain through a transfer of the gaseous oxygen in the respiratory tract across the pulmonary epithelium, as shown here. If halothane is placed in a suitable vaporizer and introduced in controlled amounts into the respiratory system, it too is transferred across the pulmonary epithelium and transported to the brain, inducing anesthesia. The depth of anesthesia is controlled by variations in the concentration of the anesthetic mixture in the anesthetizing circuit. Halothane is a potent and complete anesthetic agent. Used with due regard for its potency, it is suitable for a wide range of patients, young and old. It is not a drug for use by the unskilled, and it is imperative that the proper equipment be used for the accurate metering of the agent. Among the commonly used vaporizers are the copper kettle, the Vaporex, the Fluotech, the Goldman vaporizer shown here on the boil machine. Here is the copper kettle. It permits rapid, even vaporization at any given temperature and volume flow. This is the flow meter, used for metering gases to control the concentration of halothane delivered to the anesthetic circuit. A soda-lime carbon dioxide adsorber is usually employed with all of the anesthetic machines to be shown. This is a double-chambered canister. This is the Vaporex apparatus. A sliding scale and adjustable control allow rapid determination and setting of gas flow for any concentration of halothane desired. The Vaporex may be used on several anesthesia machines. The Fluotech vaporizer permits the maintenance of constant halothane concentrations at given flow rates and vaporizer settings. It too may be used with various anesthesia machines. This is the Goldman vaporizer, manufactured in Great Britain and shown here on the boil machine. Under normal operating room conditions, variations in temperature do not change the concentrations of halothane delivered by these devices. With a total gas flow of 3 to 6 liters per minute, manufacturers' calibrations reasonably reflect the concentration of halothane being delivered. The breathing bag should be placed between the vaporizer and the patient. If the vaporizer is placed between the breathing bag and the patient, it is possible to deliver an overdosage of halothane vapor. The premedication is administered by the nurse at the designated time to assure that the drug will have the desired effect. The anesthesiologist visits his patient prior to removal to the surgical area to ensure that arrangements are in order. Gentle handling of the patient maintains the sedative effect produced by preoperative medication. Good sedation makes the introduction to a new and strange world less frightening. The anesthesiologist supervises the positioning of the patient on the operating table and the application of a restraining strap. The arm is placed on a padded board. And prepared for venipuncture. Following the insertion of the needle into the vein, the needle is securely fixed to the arm with adhesive tape. The arm is then strapped to the board. A sleep dose of thiopental sodium is given intravenously. Following the induction of sleep, a flow of oxygen and nitrous oxide is passed through the halothane vaporizer and into the anesthesia circuit. It is important that a tight fit of the face mask be established and maintained. A face mask leak, requiring constant filling of the circuit with oxygen, dilutes the anesthetic mixture and delays the onset of anesthesia. To ensure his patient's safety, the anesthesiologist constantly observes the patient's reaction to the anesthetic. He repeatedly monitors pulse, blood pressure, and respiration, altering anesthetic concentration as indicated. He carefully records his observations in sequence on the clinical anesthetic record. The halothane concentration is gradually increased as tolerated by the patient. The drug is non-irritating and easily tolerated. Consequently, induction is not hampered by coughing and reflex laryngeal spasm. In order to provide profound relaxation of the mandible and facilitate endotracheal intubation, a short-acting muscle relaxant is given intravenously. The anesthesiologist ventilates the lungs manually by squeezing the breathing bag before performing laryngoscopy and inserting the endotracheal tube. The endotracheal cuff is inflated to provide an airtight fit between tube and trachea, and the tube is securely taped in place. While final preparations are being made for surgery, the anesthesiologist reviews his patient's condition. If hypotension occurs, the concentration of anesthetic vapor is reduced and pulmonary ventilation is improved. If a marked fall of blood pressure is noted, it is usually the result of the use of unnecessarily high concentrations of anesthetic vapor. The varying requirements of different phases of the surgical procedure are carefully noted, and the anesthesiologist adjusts the depth of anesthesia accordingly. Residents are taught to use halothane employing a semi-closed technique until they are thoroughly familiar with the properties of the drug. Beginning with induction, there is a diminished respiratory exchange which continues throughout maintenance. Therefore, in all cases, assisted respiration is maintained to provide adequate pulmonary ventilation. The lungs inflate with ease, and because of halothane's potency, the depth of anesthesia can be increased with 3 or 4 respirations. Once surgical anesthesia is accomplished, smaller concentrations of halothane are required for maintenance, and the blood pressure levels tend to stabilize. Constant, unrelenting monitoring of pulse, blood pressure, respirations, surgical procedure, and equipment is absolutely mandatory. The operation completed, the patient is carefully moved to a stretcher and taken to the recovery room. Here, recovery from halothane anesthesia is usually rapid, with little tendency to nausea and vomiting. These factors make the care of the patient in the recovery room much more simple. Complications arising from the actions of a disoriented, retching patient are avoided. With careful administration of halothane, proper supervision of anesthesia during surgery, and good recovery room care, the patient returns to his room in the best possible condition. The anesthesiologist continues his care of the patient with one or more post-operative visits until dangers of complications from the anesthesia are past. When administered by the skilled anesthesiologist, halothane is a valuable anesthetic agent, potent, controllable, fast-acting, non-explosive, and non-flammable, providing remarkable freedom from nausea and undesirable side effects.